Welcome everyone to the noon meeting. Today it's being hosted by the Health Economics Division. And we have a special presenter, senior lecturer in the division, Dr. Cunnama, who will be talking about the methods, and not the findings, but the methods for estimating costs of lymphoma cancer diagnosis at Groote Hospital. So we have an hour. We'll see. You take as long as needed, and then we'll have some time for questions and discussions.
Great. Thank you so much, Adina. Hello, everybody online. Nice that you could join us, Tara. Thank you, everybody, for joining. So today I'm going to talk a little bit about determining the cost of lymphoma diagnosis at Groote Schuur Hospital. And this is sort of the work that's in infancy, and I hope a collaboration that's going to carry on for a lot longer. But at the moment, this work was done by myself, Dr. Warisa Farid-Bray, who's just graduating at the end of this year, Associate Professor Stelferberg, Dr. Catherine Antel, who's newly back in South Africa, and then Ms. Jenna Oosthuizen. And also in the room we have Christine, who will be working on the patient cost side of things. So I'll talk a little bit more about that. But I'd particularly like to draw attention to Dr. Warisa Farid-Bray, who did some of the costing work at Groote Schuur, and I'll touch on that in this presentation. So what is lymphoma? It's a disease of the blood-forming organs, and it's usually found in the lymph node. So often one would find that one had a raised lymph node, and there are various different criteria that we would use to try and diagnose and put it into the category of lymphoma. But it's not necessarily that you would see it. So it could be in a lymph node, but it could be in a mediastinal lymph node in another area. There are around 70 different types of lymphoma, and they're classified into these two broad categories. So there's non-Hodgkin's lymphoma, and that's slightly more common than Hodgkin's lymphoma. And then the most common subtype would be the diffuse large B-cell lymphoma. So you can see it's quite a complex area with all of these different subtypes. And then the Hodgkin's lymphoma, which is considered actually quite curable if diagnosed early on. And that's a lot of the impetus that we have in terms of this early diagnosis that we're trying to achieve. So if we look at the global figures for non-Hodgkin's lymphoma, and we can see that it ranks, I think, 11th in South Africa, and I'm not sure here, 3. Also 11th worldwide, and around 500,000 individuals in a year in terms of the incidence, so new cases. And that's for both sexes. And then in South Africa, we have around 1 million incident cases of cancer in general. And when we just look at lymphoma, look at Hodgkin's and non-Hodgkin's lymphoma in this graph, we can sort of see the bar here is the incidence, and underneath in red is the mortality. We can see that it's around just over 4,000 cases, and around half of those are fatal. And then when we look at the incidence as a rate, it's around 209 per 100,000 for all cancers. But then when we look at Hodgkin's and non-Hodgkin's, it's quite low, 7 per 100,000. And what we're trying to do is to find these cases that are often quite hidden. When we then look at some of the other leading causes of death in South Africa, we have tuberculosis, and this is from 2018, so I would argue that this might need to be updated. But tuberculosis, diabetes, which we heard a great PhD upgrading this morning around diabetes, then our cerebral vascular diseases, and It's only at the bottom where we have our malignant neoplasms, but we're not even seeing the cancers really getting onto this list. So what are the symptoms of lymphoma? Often we have a swollen lymph node, glands. These can be in the neck, the armpits, around the elbow, or even in your groin. And you can have extreme and unexplained weight loss, fever, night sweats, fatigue, and shortness of breath. And living in our TB endemic environment, what this makes you think of are what are the symptoms of active TB? Coughing that lasts sort of more than 2 or 3 weeks, coughing up blood, which can be different, fever, so there we see the overlap, night sweats, fatigue, unintentional weight loss, chills, loss of appetite, and then chest pain and pain, coughing or breathing. So we've got this disease that's really overlapping, a little bit insidious. You don't quite know if it's lymphoma or if it's something else. And in our TB endemic area, we find that there's a lot of use of empiric treatments. And when we were part of the Extend trial, which Adina Sanovich is in the room, who was the PI on that, we looked at when we put in place a new type of diagnostic test like Gene Expert, do we pick up more TB? And what we found is because there's so much empiric treatment in South Africa and the clinicians are exposed to seeing so many different cases of TB, they actually become very expert at diagnosing TB with a chest x-ray and symptoms, rather than using these diagnostic tests. And when we looked at TB, we found that the methods that were being used, we actually had to do a cost minimization because the effectiveness was quite comparable between microscopy and Gene Expert PCR test. And what that tells us is that we're not seeing a huge change in the effects, but we did see a change in the cost. And then when I started doing this work in lymphoma, it made me ask some questions because we've more or less assessed that we can put Gene Expert in place. It will be beneficial. But actually, what we're doing when we're relying on that empiric treatment is that cases such as lymphoma are actually probably going undiagnosed. So it'd be quite interesting to look at the cost effectiveness of lymphoma diagnostics in light of this TB endemic area that we have. So what we did also see, so this wasn't work that Adina and I did, but others looked at in Cape Town. They looked at what was the empirical use of treatment in Cape Town, and they found that as Gene Expert was rolled out, there was this decrease in use of empiric treatment, about 50%, about 50% change. So there was a reliance onto Gene Expert, which is good for lymphoma and other diseases. But there's still about a quarter of people living with HIV with presumptive TB that are treated empirically, and that's also because of the way that symptoms present themselves when somebody does have TB and then has HIV as well. And so, although when we look at the incidence, we see that the number of cases of lymphoma are actually quite low, what we are seeing is that we're delaying treatment often when individuals are put onto empiric TB treatments and there's presumed TB and actually they have lymphoma, that interval becomes longer for them to get onto treatment. So the main difficulties with lymphoma are in terms of diagnosing because of these overlapping symptoms. And then also the inadequate tissue for subtyping. So you need a certain amount of tissue when you're doing these tests so that you can do a series of different tests to work out, first of all, it's lymphoma, and then what subtype of lymphoma is. And in some of the work that looking at next generation sequencing, you actually, as you go down the road of testing, you need to keep using new pieces of this piece of tissue that you have. And that's part of the reliance that we've had on surgical excision biopsy. Because you take out the whole lymph node, it means that you can slice the lymph node and do multiple tests on this one piece of tissue. And so that has been in the past the gold standard. With fine needle aspirates, this has been used often as a point of care test, where you put in a thin needle into the swollen tissue, take out some aspirate, so some fluid, and then you would do some testing on it. But it's not in the same level as surgical excision because you don't have the same kind of tissue. So one of the first things that we needed to do was to think about making a definitive diagnosis of TB. Because if one can make a definitive diagnosis of TB, it means that we know that those individuals have TB, we can put them on treatment. And it means that if you don't have that definitive diagnosis, you can then put those individuals into a series of tests so that you can work out what do they have. And so this is the work that particularly Catherine Antel and Stelfer Berg have been doing, where they've been using expert MTB RIF Ultra to work out if there is definitive TB. So as I alluded to, we've got surgical excision biopsy, and that's said by WHO to be the diagnostic method of choice. So we're taking out the whole lymph node. We've got fine needle aspirates. So again, putting in a needle to take out some of the fluid. But there's another way that we can approach that, and that's with an ultrasound guided 4-needle biopsy. Very similar to the fine needle aspirate, but it's a larger gauge needle, so you can obtain more tissue, but you can do it at the patient's bedside. So they don't need to be an inpatient, they don't need to be booked for surgery, and they don't need to be in theatre. And what Dr. Antel has proven is that there is adequate tissue for subtyping. So you get more tissue than with a fine needle aspirate, possibly less than a surgical excision, but enough tissue to do the subtyping. And it's also shown to decrease the time to diagnosis. And we've actually seen in some of Catherine's work, it's the interval to the diagnostic interval has reduced in some sample that he had from 48 days to 13 days. So it's a really marked change. And we can think about what the implications that has in terms of retaining our patients and getting them onto treatment. And so what they did in the hematology department was to set up these RAD lab clinics. So that's rapid access diagnostic lymphadenopathy clinic, or RAD lab for short. And so the idea is to try and streamline this process. So referrals letters were sent out to all the peripheral facilities around Groote Schuur to say, please send in any patients that have swollen lymph nodes, and they gave the diagnostic picture to our clinic. They hold the clinic on a Tuesday, and then using this core needle biopsy, they were able to speed up the process of diagnosing patients. And they have around 500 patients in their databases. So they really have found that the incidence seems to be higher in Cape Town than was previously thought, just because those patients were hidden in our TB endemic area. And obviously the disease does progress if it's not treated. So those RADAC clinics have been very useful. And so if we think about what the pathway looks like, you've got this enlarged lymph node plus symptoms. You generally would go to a GP or a clinic. And what the RADLAC clinic is doing is that we're then sending those patients off to be diagnosed at a tertiary specialist clinic, so these core needle biopsy clinics. Otherwise, they may go into a route where there's a high suspicion of TB, limited cytology. They either have an FNA and there's potentially no diagnosis because you're literally taking fluid, you might miss the actual piece that would show you that you had lymphoma. So the patient's falsely reassured, then they go back to the GP at some point or back into the system at some point, but they have this delayed diagnosis. Or there's still this high suspicion, they're put onto empiric TB treatment, there's no response to TB treatment and they circle back. Or there's a response to the TB treatment, which confirms our diagnosis, and then the use of this pathway is reaffirmed. It is also possible for a patient to have TB and to have lymphoma. Very possible. And so the idea with the novel or ideal pathway is to try and link at the point where the patient goes to a GP or clinic, and obviously this is needed so that the doctors that are referring and the nurses that are referring do refer to these clinics that are doing core needle biopsies. And then there are different pathways that one could take in terms of the type of lymph tissue that you're dealing with, making sure that there's this ultra test to exclude TB, and that can be an FNA that's used, and then to make sure that we get a confirmed diagnosis. And the success of this is that as patients are treated, the word gets out that Groote Schuur will take these patients. And so it has been really good, and we've seen a lot of patients going towards Groote Schuur. And that leads me to the project, which is a cancer group grant, so Cancer Association of South Africa, the title of which is Improving Cure for Lymphoma Patients in South Africa by Enhancing Access to Early and Accurate Lymphoma Diagnosis. And phase one of this project is to, first of all, streamline these RADLAC clinics at Groote Schuur and in Tygerberg, where they are already present. At Tygerberg, at the moment, they don't have the same referral system. It's more that within the facility itself, if there's a patient that appears to have symptoms of lymphoma, they are immediately sent. Yes?
Can you mute that first?
Yes, I can.
Close it against that one. Thank you.
Sure. And so there's a streamlining process. It's already quite smoothly running at both of these facilities. It's more just making sure that they are working well and keeping on collecting the data that's at the facilities. And then setting up these RADLAC clinics at 2 more sites, so at Victoria Hospital and at Worcester Hospital, which are both secondary sites. Again, with the idea that they would support the surrounding area. So around Worcester Hospital, which is a secondary facility, the patients could then access this at an outpatient level. And then Christine will be doing some patient costing at Groote Schuur and Tygerberg, looking at both the direct and indirect costs of the patients accessing these services, and also trying to think a little bit about the coping mechanisms, some of the catastrophic costs that they might be incurring, and thinking a little bit about some of the intangible aspects, so thinking about pain and discomfort and those kinds of things. Then we'll also be looking at the costs of setting up these new RADLAC clinics at Victoria Hospital and at Worcester. At Worcester, there may be a slightly different model, as the buy-in at the moment is from the surgeon himself. So the head surgeon at Worcester is incredibly, he's a champion, one of these individuals that's setting up multiple services across the site. And so there may be an inpatient and an outpatient component. And then we'll try and look at the cost effectiveness of core needle biopsy as opposed to surgical incision biopsy, this is going to be quite a difficult thing to do because we're not looking at effectiveness measures in the usual sense. And so we'll have to be quite creative, I think, about how we go about looking at effectiveness. And we know that in terms of sensitivity, trying to actually look at in terms of effectiveness. So it may be that we look back at this data set of patients already at Groote Schuur and look at the cascade of care, and in that way do some modeling to see what is the case. And then we want to try and estimate the national scale-up and budget impact of such a scale-up. Again, we need to see, so this clinic has worked incredibly well at Groote Schuur, but we know that Groote Schuur is a tertiary level facility with a lot of specialists. And even at Worcester, where we have this champion, we need to be cautious that we don't put it into a level of facility where it's actually going to be detrimental. So I think it seems as if core needle biopsies can be done quite well at point of care with the right training. So if that training is provided, we may some firstly, what is the need, so the burden, and the burden itself is actually, in a sense, quite low, but it's trying to pick up those patients that are good. And then when we were looking at, so Marisa looked at the cost per outpatient with lymphoma. So when we looked at surgical excision biopsy or with ultrasound guided core needle biopsy, we looked at the standard aspects of capital costs, overhead costs, human resources, consumables, and these were all allocated out and then multiplied by the number of visits, and we added the medication and other diagnostics. And what we found was that fine needle aspirates are around $235. Core needle biopsies are around $278, so actually not that much more than a fine needle aspirate. And then surgical excision is around $332. The caveat being that the fine needle aspirates for this particular group that we looked at, they're not doing a lot of fine needle aspirates. And so it could also be an economies of scale concern, or it could be that the cadre of staff that are doing the fine needle aspirates at Groote Schuur are very high, and actually at a lower level facility wouldn't be a specialist physician doing the fine needle aspirate. So we'll do some work on our sensitivity analysis there. And then also with the core needle biopsy, this is actually the more expensive option, because a barred gun is a capital item that you actually then reuse, whereas you actually do get a disposable gun. And when I talk about gun, it's basically a device that helps you to take this core. So you have a needle that you put onto it, you take a core sample with this gun. And this also includes an ultrasound, but there are a lot of cases where the physician gets so good at doing the procedure that they don't actually need an ultrasound to guide them. And it can be more tricky because you're basically holding a handheld ultrasound device, trying to manipulate the person's lymph and then taking a sample. So in a lot of cases, individuals actually get really good at doing it without the ultrasound. So they may be less need. So that's, again, one of the sensitivity analyses that we've done, is to look at it without ultrasound. There is potential for using other devices. So the surgeon that we met with at Worcester spoke to us quite a lot about using sort of in a similar way to Google Glasses, but some sort of headset where you're videoing and you can actually get a remote person who's a specialist to help you with the process. So sort of a mentor or a teacher. Also hard for you to see, but as usual, the personnel costs are quite high. So that's our purple section in both the surgical excision and the core needle biopsy. And that's, again, because of the cadre of staff that are doing these procedures. The consumables and medication are these chunks at the bottom, these parts of the pie. And then the procedure tests. So linked to this, we would like to do a gene expert, look at TB, autoimmune, TB, Zeal-Nielsen, TB culture, and then the histology, PCR. So there are a lot of diagnostic tests that are linked as well. And so that's also driving the cost. Some of the costs that are quite difficult to tease out are that the surgical, well, they're difficult to tease out at a facility like Groote Schuur. So surgical excision biopsy is offered in a theatre. You have to be booked in, and so there's this opportunity cost. And so you could be using that facility for different purposes. The patients are also often lost, or it could be lost to follow-up because of the lag between time that they are diagnosed, well, time that they hear with their symptoms to having this surgery to have the excision. And so the disease can progress quite quickly in that period. Whereas core needle biopsy can be done point of care and there's not a need for surgery. Some of the cases we were seeing at Groote Schuur that they were still being done in the theatre, and that was more or less for the convenience of the team, because the surgeon has what they call a lumps and bumps clinic, and so the patients are added to the list. And although he's doing core needle biopsy, it's being done in theatre space. One could argue that that theatre space, in particular at Groote Schuur, is an old theatre that wouldn't actually be used for surgery, but in terms of our economic costs, we wanted to cost it as a theatre in this case. And then both supply adequate tissue for testing. So again, there's this, in some places, surgical excision is preferred because you get a bigger amount of tissue for this additional testing. And also in the future, there may be a need to retain the tissue. So there are biobanks at Groote Schuur and at Tygerberg where the tissue is basically frozen very quickly and then can be used later on when we have different tests and can be used for training purposes and so on. So there's a slight argument for trying to retain some of the tissue, but actually in terms of subtyping for that individual who has the lymphoma, there isn't a need to do the surgical excision. So again, the core needle biopsy seems to have quite a few different benefits. And then in terms of what has been seen when patients are thought to have something that appears in this way, so it has the symptoms of lymphoma, when Estelle and Catherine have been putting these patients into categories or giving them diagnoses, basically you found that there is TB, lymphoma, and then malignancy of some other kind, and then a small portion of other disease. So it's when one has these kind of lumps, generally those are the three categories that somebody would be put into, and more or less in equal measures. That's what I wanted to show you today. So yeah, it's a work in progress, and I think Jennifer Moody is also on the call, and hopefully we'll be able to expand the work that we're doing in terms of economics in cancer and move forward with this work and this other work that we're doing.
Thanks very much, Lucy. A very clear presentation and very interesting. I've learned a lot today about lymphoma and different diagnostic options that we have these days. So I think I'll open the floor for questions. Maybe start here with the room. Are there any questions for Lucy or comments?
Do you mind if I go to Jennifer? She's got her hand up on the
Please go ahead.
Prof. Mutley, please will you go ahead?
Thanks so much, Lucy, for a really, really interesting presentation. This is such an important field, and so really looking forward to your results. I wanted to just add that, you know, for these patients, and there are a few cancers that follow this, where there's often a symptom overlap. So at a primary healthcare level, it is incredibly difficult to know what the diagnosis is. And a person who comes with a lump, very few of them end up having cancers. So there's often these multiple visits. So I think where you're going to see a real difference in the cost is when you do the patient-related costs. Because if we can reduce the number of visits that the patient is making, so quicker referral to your hopefully decentralized, you know, district level rapid clinics, that's going to make a huge impact in terms of patient costs, as well as in destigmatizing cancer, because if patients just make multiple visits and end up coming late, then the view is that cancer is a death sentence when it doesn't have to be. So I think it's useful to, you know, to see the broader impact of this earlier diagnosis that's happening. It's not just the cost, but also just destigmatizing the whole disease. So well done. I'm really looking forward to discussing, you know, your results as they come out. Thank you.
Thanks so much.
Lucy, I just
Yes.
didn't understand. Did Jennifer say that only a few cases are actually cancer and most cases are not?
Well, when you sort of take the whole population, so anybody that has a lump that then goes to a GP or to a clinic, you'd only have a small percentage of those that actually would need this level of follow-up, and also that would be diagnosed with a cancer. So there are a lot of different diseases that we would have that would create a lump in your neck. So you could have just a fatty deposit, or, you know, there are multiple different things that you could have. And so I think what Prof. Mutley is saying is, if we can speed up when patients are seeking a diagnosis, we can speed up that process. That means that the delay is so much less, that the progression would be less, and therefore the fatality could also be minimized.
So does that mean that the test could be seen as a screening test rather than a diagnostic test, in that you can say yes, or you can say it's not cancer as opposed to it is cancer? What is the?
I mean, I think there may be quite a lot of hesitation in terms of using it as a screening test. Just there are risks in terms of taking a biopsy, even with you know, this kind of gauge needle, because you are putting it into quite a sensitive area of your neck often, or, you know, even so it's not entirely without its risks, but I'm not sure if they would head towards using it as screening or not. I think, yeah,
So maybe I'll
I'm not sure.
rephrase my question.
Yeah.
Do you get the definitive diagnosis after these tests are done?
So I think that the important thing is to use the TB, so the Gene Expert Ultra, to make a definitive diagnosis for TB. That would help the case for cancer and for lymphoma in particular, because then you could use the core needle biopsy so you could use a fine needle aspirate for the ultra, and then you could do a core needle biopsy on those that didn't have TB. So that pairing could be very beneficial. And if we can reduce the lag between somebody having a fine needle aspirate and a core needle biopsy, that they don't just keep going for repeat fine needle aspirates, that would be, I think, we would see a big difference. Yeah.
I do have a question relating to the effectiveness. You said that you may attempt doing a cost effectiveness analysis, but the problem is how to measure the effectiveness. It's not a trial, it's really the data that you have at hand. So my question would be, did you do any literature review to see if similar studies have been done elsewhere and how effectiveness could be measured?
I haven't done extensive literature searches, but I've looked a little bit, and there's some evidence for the core needle biopsy being effective, but not. I haven't found anything very extensive. Keep looking. I think we'd probably be looking at sort of time to diagnosis. It's difficult because you've got time to diagnosis and then you've got time to treatment. And then I guess you could look at life years saved. Yeah, I'm not quite sure how to do it yet.
I think it's a fine line between correctly diagnosing and incorrectly diagnosing. So, but you said that the specificity and sensitivity of both are similar.
Similar. Because also once you're diagnosed, obviously you need to go on to treatment. So there's a whole, I mean, at the moment we're really focusing in, well, myself and Christine and others are focusing in on early diagnosis, but there's a whole nother phase of treatment. And so, yeah, I mean, I guess we could look at it, but again, with the Stell's work, they've been also focusing in on making sure that diagnosis is made. And I don't know how good their data is on retaining those patients in care in terms of treatment.
There's so many unanswered questions there. Yeah. So I hope you get some of the answers as you go along.
Yeah. One of the other things I thought about doing was when you and I worked in TV, when we were working with the Global Health Costing Consortium, and we categorized all the interventions, so active case finding, passive case finding, and so on, and then broke it down into components. It would be really useful to do that for firstly lymphoma and then try and expand it for different cancers.
Sure, that would be. There's so little research, particularly health economics research in the area of cancer, that there's so much for you to do actually going forward. So definitely one of the ways of looking at the cost would be to replicate something similar to GHCC. Okay, any other questions from maybe online again? Questions? Yeah, just from the room. Comments? Suggestions for Steve? So can lymphoma be diagnosed correctly using these tests?
Yeah.
There aren't really many false positives or false negatives.
No, I don't think so. I think so. I think the problem comes when you don't have an adequate tissue sample. So you can't. Well, I don't know. From what I've learned from the others that know a whole lot more about this, it seems that some people are very good at using fine needle aspirates, but for the most part, you're not going to get enough tissue to actually be able to diagnose. So, and that leads to that false reassurance that actually there's no problem. So I think the fine needle aspirates for me seem to be the area where that can lead to misdiagnosis. But in terms of core needle biopsy and surgical excision, no. Once you've removed that tissue in that way, you'll be able to tell that it is lymphoma or a malignancy or TB.
So as you know, in economics, we're not really always trying to save. We're happy to invest in better procedures as long as you can show that they're more effective and they save more lives. Or in the long run, they save future costs from treatment and obviously particularly save lives. So I think looking in depth between these two alternatives, surgery may be the way to go if the effectiveness is shown to be better. However, it may not be the case with patient costs level, as well as the time to diagnosis.
Yes, and I think that's going to be key. So time to diagnosis could mean that actually there is cost saving because you are catching those cases earlier on. So in terms of productivity, you'd probably be winning. And in terms of getting those patients onto treatment and being treated successfully, you'd probably be doing much better. So in that way, I think you'd lean towards the core needle biopsy. But I think it needs some work in thinking about the time from diagnosis to treatment, as well as time from symptoms to diagnosis.
I was going to ask about the age group. Most of those 500 patients, for example, that you have in the database, what is the age of those patients?
So I actually can't tell you.
Maybe adults or children?
So I think majority are adults and older, but I haven't looked at that data in enough detail to be sure.
I have a comment, which is that was incredibly clear, and I thought it was a really interesting overview of the issues, and great to see this coming together with sort of some multiple student involvements and the whole thing sort of being stitched together beautifully. And the one other thing that I found really interesting was the way you sketched out the interplay between the rollout of experts and some of the unintended consequences of that, and how that actually also then plays into positive potential consequences for the diagnosis of other conditions, which from a theoretical perspective is quite interesting for economic evaluation, because we're supposed to focus on the scope of costs and outcomes in theory is everything that changes as a result of the introduction of a new intervention. And in practice, that's impossible. But it was really interesting because, I was not a fan of expert because it was not cost effective. But here we're seeing how expert actually has potential added benefits, which were unforeseen at the time, unknown. And so I thought that was a bit of a light bulb moment.
It's also been interesting to see. So Adina and I did some work in HIV, which is considered quite well funded, and then TB is considered not so well funded. But when I've now been working with the hematologists, cancer and particularly lymphoma is so underfunded. So they look to TB and say, well, TB gets all the money. And when we're working at TB, we think, oh, HIV gets all the money. So it's quite fascinating to see the different groupings, and obviously funding drives some of what we do, drive everything. Are there other questions from the online?
Okay, maybe does Christina want to share more ideas? Where are you at your?
Okay, so I'm still quite in the early stages. I'm currently developing a patient questionnaire that we're going to use to determine the patient costs. So that's as much as I can share at this stage. It's still quite early, but I'm really excited and looking forward to this work. I think it's really potential.
What is the sample size you're thinking of? All 500 patients?
No, I don't think so. Definitely not all 500. That would be great. But I think we're thinking of much smaller samples.
So that 500 patients, Adina, they've been collecting for a very long time.
Sure.
Yeah.
Track them down would be possible.
I mean, I think if we can, I don't know how many we'll find at the facilities, but they get sort of a handful every Tuesday. So it's really not a lot of patients, but yeah.
You'll have to specifically
Maybe
get to the largest sample size of 20 will be less. in terms of shedding and the like of the cost.
Yeah.
And then focus on maybe different age groups, particularly those in age groups, and county loss from work, seeking care or being off for reason for being sick and staying at home. So perhaps that age group would be relevant because there's a but the larger the sample size, the better. And the more meaningful, if you are attempting and doing the cost effectiveness analysis. I was reading the other day about sample size, inpatient cost surveys.
Oh, really?
And not
Please
much.
share.
Well, Lucy was the one who helped a lot. So thanks very much for that survey report from Kenya, as well as WHO guidance. Well, with the patient costs, survey sample size estimate, we always in the past used the statistical approach, where you have your, let's say, 95% confidence interval at 5% margin rate for error, and you get up, like, let's say, a sample size of, let's say, the population in need of 300, it works out at 180. The sample size should be for the patient costs. And that's what we used in the past. And I think that's very much prevalent. However, I found out that if you're now going to use the patient cost data or estimates in a cost effectiveness analysis, so moving up one level, then you need to have at least between 200 and 400 patients interviewed. I mean, there's a lot of debate around it, and not a lot of patient cost surveys have been done. So we can't really refer to and even say it's too big a sample size or not. But at least I would say, at least 180, not more.
But you shouldn't use your patient costs.
And no, you can report them separately, of course. But if the cost effectiveness is done alongside an randomized controlled trial, where you also interview patients for patient cost analysis, then you should aim for something like that. But there's so much unknown. And or I would recommend that you get use purposive sampling or interview everybody. Extend the time period so that you get as many patients interviewed.
That should be realistic.
Yeah.
Yeah, I mean, when we did the Valley TV work, which was not patient costing, but looking at facilities for costing, and that's considered one of the biggest studies for looking at costing. And we had 20 facilities in Kenya, and
We had an 8 of 20.
yeah, and it was a huge amount of work. And that made such different things in different countries. So Georgia, it really made almost all of the facilities TV. And in India, it made really, it wasn't representative because it was only, we looked at 2 districts or something in this enormous country. They're looking at about sort of close to 1,000 patients, so about 900 patients for the TB cost surveys that they're doing, patient cost surveys that they're doing for WHO. But the funding in comparison to the funding that we're seeing for some of the patient cost surveys that we're doing, so a lot more. But it's quite nice when you see it at such scale, because you've got each of these countries well represented. And then you can do that cross-country comparison, because they're up to about 27 countries. You can really start looking at the catastrophic spending. So for TB, for drug-susceptible TB, it's about 50% of the population is spending catastrophically.
Wow.
And for multi-drug resistant, I think it's 80. And the amount that they're using as a threshold is 20% of the household income.
And that must work.
They have indirect costs in there. Yeah.
What is driving it?
I haven't really looked at their reports in terms of what's driving it.
Probably last week.
As opposed to spending itself.
Oh, yeah. Particularly the multi-resistant TB, time spent in the hospital, so definitely would be lost income.
So Donor Sweeney's just done it for South Africa, so it'll be really interesting to see what that looks like. So,
Yeah. I mean, unfortunately for us, because of unemployment, there's no costing. Which doesn't mean anything good, right?
True.
Just to start with. Difference.
So Lucy, back to like those clinics.
yes,
So I think the idea would be going forward to have them at the lower level of care. That's how you're going to reduce the cost and also get the patients to get screened sooner, as opposed to having to travel to all these big centers. So I think maybe we can also look at that. That could be an angle. Really looking at levels of care and where these clinics should be placed.
yeah. Yeah, because Philip, Matthias and I had tried to look for TB at using sort of GIS software, so mapping software, to try and say, in terms of transporting specimens to a facility, what made sense. And you could do something in a similar kind of way, because you don't want to have, well, I mean, if it's a low cost thing, you could have it that it's quite dispersed and that you train people well. And so that these individuals that are spread out that can do this to form the service. But there's probably some advantage to retaining some control on it as well, and having it at some central points so that it's not too decentralized, so that there's not, I don't know, yeah, I think districts probably can get on.
And
This is the numbers can be huge, right?
No.
Yeah, it's not like TV where you have to have it every clinic.
isn't also TB hospital? Don't they have a large TB, or at least pediatric TB?
I know that SACME is affiliated with Worcester and that it's a referral to Tigerberg. I'm not sure if their TB is specializing.
TB vaccine candidate trial took place there. Okay. But they're obviously focused on small children.
Yeah.
So maybe the idea would be to have them at centers where TB is prevalent.
Yeah.
Because you're uncertain about whether it's TB or lymphoma. So if you want to test both, you target the clinics or the district level hospitals where there's a huge load of TB patients.
Yeah.
On the same site as the hospital is the day hospital clinic. Well, the referral center here.
It was
The same site.
Yeah. These RADLAC clinics are performed as outpatient services. So that's also the difference. So surgical precision, you actually need to be admitted, whereas actually you should be seen as an outpatient in the majority of the time.
That's a very nice spin that you've taken, TB and pharma link,
Yeah.
because there's so much in common.
Yeah.
Hope you'll find some interesting insights
Yeah.
going forward. How long is the project for? When do you?
So it goes for, I think it's 5 years.
Wow.
Yes. Maybe it's till 2026. But they're different parts. So phase 1 is sort of setting up the study, and then there's a whole part that goes into the subtyping as well. So they're going to try and use machine learning to subtype all of these different types of lymphoma as well. So taking tissue and working out what it is, but then also trying to use an algorithm to see what it is and see if the machine learning can work out in a similar kind of way to it. So it'd be fascinating to see how it plays out. But I think in terms of diagnostics, there's so much happening. So Catherine has just got 2 big grants, and there's going to be a lot of work going into next generation sequencing, but also liquid biopsy. So taking blood and screening blood for cancer. Seems quite intuitive as a layperson, but it's quite advanced.
Okay, let's just if there are no questions. Are there any questions there? In the chat box. No. Okay, so if there are no questions, I've got you again very much. Very interesting, and all the best with your research.
Thank you.
Hopefully in a year or 2 years' time, we'll have something to report back.
Yeah.
Wonderful. Thanks, Lucy.
Thank you very much.
Thanks, everyone.
Thank you. Bye.